Hello, and welcome to this weekly pelvic perineal literature watch for June 26th, 2026, presented by Erwan Lerumeur, physiotherapist in Paris. This is scientific information only, not individualized medical advice. References are available in the description. This week, the watch reviewed 80 articles. The main dossier focuses on pelvic organ prolapse, estrogen, pessaries, surgery, mesh, frailty, sexuality, and long-term outcomes. We will then broaden the picture with 6 must-read papers: neuromodulation for urgency, urinary incontinence, postpartum urinary incontinence at 3 years, rehabilitation for stress urinary incontinence, sexuality 12 years after OASIS, rectovaginal endometriosis, and bladder-bowel links. Dossier of the week: pelvic organ prolapse, from vaginal tissue to 10-year outcomes. First point: perioperative vaginal estrogen, Vacca, Piero, Foresta et al., published in Climacteric, a systematic review and meta-analysis on the use of vaginal estrogen around prolapse surgery in postmenopausal women. 9 randomized trials were included, for a total of 764 women, 383 in the estrogen groups and 381 in the control groups. The authors assessed tissue quality, vaginal atrophy symptoms, urinary tract infections, complications, satisfaction, and composite surgical success. The main result deserves a precise reading. Vaginal estrogen significantly improved tissue quality with a standardized effect size of 0.73. Vaginal atrophy symptoms also improved, and the safety profile was considered excellent. However, the effects on urinary tract infections were uncertain and contradictory. 1 study suggested possible harm, while 2 studies suggested benefit. Composite surgical success showed no significant difference between groups. Satisfaction remained very high, above 95%, with or without estrogen. So the message is not that estrogen improves everything. The message is more limited, and that is exactly what makes it useful. In postmenopausal women undergoing prolapse surgery, vaginal estrogen may improve the vaginal tissue environment and atrophy symptoms, but this meta-analysis does not show a clear improvement in overall surgical success. This forces us to separate objectives. Improving an atrophic epithelium is not the same thing as preventing recurrence, reducing urinary tract infection, decreasing complications, or increasing anatomical success. The prescription may make sense for a tissue-related or symptom-related objective without becoming a promise of better surgical outcome. This point echoes the review by Tsuboi, Inoue, Hirayama et al. In Maturitas, dedicated to gut, vaginal, and urinary microbiomes in genitourinary syndrome of menopause. 23 studies were included, with more than 5,000 participants. In postmenopausal women, the authors consistently found reduced lactobacillus abundance and increased microbial diversity. Estrogen therapy may partially restore lactobacillus dominance, but this restoration does not always predict symptom resolution. In prolapse, this background matters. Dryness, dyspareunia, discharge, urinary tract infection, pessary use, surgery, and vaginal atrophy often meet in the same consultations, but they do not all rely on the same mechanism. A hormonal or microbial lever may modify the tissue environment without by itself explaining device tolerance, surgical outcome, or sexuality. Second point: pessaries. Brown, Rantel, Anders et al., published in Neurourology and Urodynamics, a United Kingdom guideline on best practice for the use of vaginal pessaries in pelvic organ prolapse. The abstract was not available in the raw file, so we need to be cautious about the details of the recommendations, but the topic is structurally important. A pessary is not just an object inserted during a consultation. It is a therapeutic strategy involving model selection, clear information, sometimes self-management training, surveillance of the vaginal epithelium, and a plan in case of pain, discharge, bleeding, expulsion, or discomfort. Success is not just that the pessary stays in place. It must be tolerated, monitored, and compatible with the patient's goals. Yin, Li, and Zhou published in International Urogynecology Journal a secondary analysis of a randomized trial on vaginal adverse events in pessary users. The study included postmenopausal women with symptomatic prolapse of at least stage 2, fitted with a ring pessary with support. Among 411 women with at least one follow-up visit, 119 developed an event related to the vaginal epithelium, or 29%. These events included erythema, abrasion, erosion or ulceration, vaginal bleeding, and excessive discharge. Risk factors included a longer time since menopause and more advanced prolapse stage. Conversely, active sexual life and continuous estrogen use for at least 12 months appeared protective in this analysis. These are associations, not universal rules, but the figure matters. Nearly 1 in 3 women had an epithelial event during follow-up. This reminds us that pessary follow-up is not a formality. It influences tolerance, adherence, and sometimes the continuation of conservative treatment. Another practical paper, Oláh, Romix, Koeninger et al. Compared in Gynecologic and Obstetric Investigation, long-term pessary therapy, and colpocleisis in elderly, sexually inactive women with severe prolapse. 76 women were included, 30 treated with long-term pessary therapy, and 46 with obliterative surgery. Both strategies strongly improved vaginal bulge sensation, discomfort, palpable mass, and obstructive voiding symptoms. Satisfaction was high in both groups, 90% with pessary therapy and 97.8% after colpocleisis. Symptom improvement, however, appeared greater after surgery. Pessary therapy was discontinued in 23.3% of cases, and 20% of patients in the pessary group later required prolapse surgery. No reoperation for recurrence was reported after obliterative surgery. The study is retrospective, small, and used a non-validated questionnaire, but it frames the alternative well in this specific population. Pessary therapy can work, colpocleisis can also work. The two options do not tell the same story. One is conservative and reversible, but requires follow-up and may be interrupted. The other is more definitive, but involves vaginal closure, which makes it compatible only with certain sexual situations. Third point, surgery and long-term outcomes. Nager, Visco, Richter et al. Published in JAMA Surgery, the 10-year results of a randomized trial comparing 2 strategies for uterovaginal prolapse. Vaginal sacrospinous hysteropexy with graft preserving the uterus versus vaginal hysterectomy with uterosacral ligament suspension. The study was multi-center, conducted at 9 sites of the Pelvic Floor Disorders Network in the United States. 175 women were included in the intention to treat analysis, 88 in the hysteropexy group and 87 in the hysterectomy group. The initial follow-up was masked for 5 years, then extended open label up to 10 years. 112 participants, or 64%, took part in the extended follow-up. The primary endpoint was a composite failure outcome, retreatment of prolapse, prolapse beyond the hymen, or prolapse symptoms. At 10 years, failures were less frequent in the hysteropexy group, 35 out of 88, or 40%, versus 46 out of 87, or 53% in the hysterectomy group. Time to failure analysis gave an adjusted hazard ratio of 0.64, with a confidence interval from 0.41 to 1.0, and a p-value of 0.05. Both groups showed sustained improvements in patient-reported outcomes. The authors found no difference between groups for urinary symptoms, bowel symptoms, sexual function, dyspareunia, or clinically important complications. This is one of the strong papers of the week. It provides long-term data, which remains uncommon in prolapse surgery. It does not settle the mesh question on its own. It gives data for a precise procedure in an experienced network with a trial protocol and 10-year follow-up. Yang and Huang published in the Journal of Minimally Invasive Gynecology a retrospective study on vaginal native tissue repair across frailty levels. The study included 706 women undergoing vaginal total hysterectomy, modified McCool coldoplasty, and anterior and posterior colporaphy. At 12 months, postoperative bulge sensation and postoperative voiding difficulty were rare and comparable between frailty groups. Frailty was not independently associated with these two outcomes. The limitation is central. The frailest patients were few and highly selected. The group with a frailty index of 3 or higher included only 36 patients. The findings should therefore not be extrapolated to dependent, highly comorbid, or medically high-risk women. The value of the paper is that age alone is not enough to describe surgical risk. But frailty has clinical value only if we know who was included, who was excluded, and which outcomes were actually measured. Horneman, Bosserhoff, Coltan et al. Published in International Urogynecology Journal a prospective observational study on mobility after partial semitendinosus tendon harvesting in prolapse surgery using the HOTT method. 142 women with stage 2 to 4 prolapse were included. Mobility was assessed before surgery, then at 6 weeks, 3 months, and 6 months. Mobility scores did not worsen. They even improved over follow-up. Higher age and higher BMI were associated with lower odds of achieving a high mobility score. Satisfaction and quality of life improved, and 96.6% of patients would recommend the procedure. This is a single-arm series on a specific technique. It does not allow comparison with other surgeries. But it answers one precise question. In this cohort, partial semitendinosus harvesting did not appear to cause measurable mobility impairment at 6 months. Fourth point, mesh, anatomical outcomes, and sexual experience. Beer, DeBoos, and Gresswell published in BMC Women's Health a systematic review with thematic synthesis on the sexual and relational impacts of transvaginal mesh injury. 9 reports were included, 6 published studies, 1 unpublished doctoral thesis, and 2 government inquiries. The data were heterogeneous, but the authors conservatively estimated that 1,483 participants were represented. 8 reports were rated as high quality and 1 as moderate quality. The synthesis identified 7 themes: changes in sexual function due to pain, changes to sexuality, changes in relational activity because of pain, changes in relationship satisfaction, altered sense of self, changes in relational roles, and a central theme around a disrupted embodied sexual relational self. This article does not measure recurrence rate. It does not compare 2 techniques. It describes what a complication can produce in sexual, relational, and bodily life. It should be read alongside surgical studies, not instead of them. The 2 levels of information are different. On one side, durability, composite failures, symptoms and complications. On the other, lived experience when a complication becomes chronic pain, sexual avoidance, relationship disruption, or a change in the relationship with one's own body. End of the Prolapse dossier. This dossier gives a fairly complete picture of the field: menopausal environment, tissue quality, microbiome, pessary use, epithelial events, uterine preserving surgery, native tissue repair, frailty, reconstructive techniques, and sexual consequences of complications. Prolapse appears less as a simple opposition between conservative and surgical treatment than as a series of decisions: which symptom dominates, which risk is acceptable, what follow-up is possible, which aspect of sexuality must be preserved, what durability is expected, and which complication would be least acceptable for this patient. Must read number 1, implantable tibial nerve stimulation for urgency urinary incontinence. Mangel, Miller, Erickson et al., published in International Urogynecology Journal, a quality of life analysis of the Intibia pivotal trial. This was a prospective, randomized, double-blind, sham-controlled trial conducted in the United States and the Netherlands in patients with urgency urinary incontinence. 208 subjects were randomized, 139 to active implantable tibial nerve stimulation and 69 to sham. Subjects in the sham group crossed over to active treatment after 3 months. At 3 months, more patients in the active group reported being much better or very much better, 29.2% versus 13.4%. The active group also more often exceeded the minimal clinically important difference on overactive bladder-specific questionnaires, 62.8% versus 41.8% for symptom bother, and 57.4% versus 42.4% for health-related quality of life. At 12 months, 83% of subjects in the active group reported some level of improvement compared with baseline. The strength of the paper lies in the sham control, which remains too rare in neuromodulation device trials. It is not only about showing that a symptom changes, but about testing whether patients perceive a specific improvement beyond the procedure effect and therapeutic expectation. Must read number 2, postpartum urinary incontinence at 3 years. Carneiro, Amorim, Moraes et al. Published in World Journal of Urology, a Portuguese longitudinal cohort on the course of urinary incontinence up to 3 years postpartum. 139 women were followed. Urinary incontinence prevalence was 51.1% in the first week, 23% at 1 month, 41.2% at 1 year, and 38.1% at 3 years. Stress urinary incontinence was the dominant subtype across all time points. In women with persistent symptoms, severity tended to progress from mild to moderate toward moderate to severe. Higher BMI and gestational duration of at least 39 weeks were associated with persistence of symptoms at 3 years. The clinical message is important. Early improvement does not mean durable resolution. The trajectory is not linear. Some women improve, others relapse or remain symptomatic later on. When continence is the issue, postpartum care does not end with the early postnatal check. Must read number 3, rehabilitation for female stress urinary incontinence. Xu Wang et al. Published in BMC, Nursing, a best evidence summary on rehabilitation management for female stress urinary incontinence. 48 studies were included. Best practice resources, clinical decision tools, recommendations, evidence summaries, guidelines, systematic reviews, and expert consensus papers. The authors summarized 51 recommendations across 5 domains: screening and assessment, lifestyle management, pelvic floor muscle training, follow-up, and health education. This is not a randomized trial. It is a strategy synthesis. Its value is operational. It brings together the components needed to build a structured care pathway beyond the simple phrase, "Do pelvic floor exercises." The content is relevant to the initial consultation, follow-up, adherence, progression, and education. Must read number 4, sexuality, 12 years after OASIS. Baud, Deram, Lepijan et al. Published in Sexual Medicine, a 12-year follow-up cohort after obstetric anal sphincter injury. Complete questionnaires were returned by 52 women in the OASIS group and 141 control women. Global sexual function scores assessed with the FSFI did not differ significantly between groups, but 2 items remained more frequent among women with OASIS: lubrication, less than half the time during sexual activity, and pain during vaginal penetration about half the time or more. The result is nuanced. The total score does not tell the whole story. At 12 years, the global difference is not major, but some domains remain affected. For obstetric sequelae, items matter, not only the summary score. Must read number 5, rectovaginal endometriosis, surgery versus hormonal treatment. Werner, Velho, and Mexner published in Archives of Gynecology and Obstetrics a retrospective cohort on rectovaginal endometriosis treated either by surgical excision or by hormonal treatment alone in a tertiary center. 210 women were included, 164 in the surgery group and 46 in the hormonal group. Around 80% of women in both groups reported improvement in pelvic pain and dysmenorrhea. Improvements in dyspareunia, dyschezia, functional symptoms, quality of life, and satisfaction were also observed in substantial proportions. Direct comparisons did not show a statistically significant difference between symptom trajectories, but the analysis was exploratory. The paper does not demonstrate equivalence between surgery and hormonal treatment. It shows that in this cohort, both strategies were associated with patient-reported improvement, and that the choice should remain linked to lesion profile, symptoms, operative risk, life plans, and preferences. Must read number 6, bladder and bowel, OAB and IBS phenotypes. Sun, Gao, Xu et al. Published in World Journal of Urology, a prospective observational study on patients with both overactive bladder and irritable bowel syndrome. 144 patients were allocated to 4 non-randomized strategies: bladder-targeted monotherapy or dual therapy, and bowel-targeted monotherapy or dual therapy. Results were analyzed according to bowel subtypes: diarrhea predominant, constipation predominant, or mixed. Dual therapy improved symptoms, mood, and quality of life more than monotherapy. But the most interesting point was heterogeneity. The effect on overactive bladder varied according to irritable bowel syndrome subtype. Uroflowmetry patterns also differed. Some patients appeared more pelvic floor driven, others more central sensitization driven, and others more bladder primary. The study was not randomized. It therefore cannot establish a superior strategy for everyone, but it offers a useful reading of patients who do not fit into a single category. Bladder, bowel, mood, pain, and quality of life may belong to the same clinical picture without sharing the same therapeutic entry point. Brief clinical bonus, a few signals are worth keeping in mind. Male slings after prostatectomy maintain acceptable 10-year outcomes in good candidates, especially in mild to moderate incontinence without prior irradiation or urethral surgery. In neurology, the artificial urinary sphincter often provides high rates of social continence, but quality of life and intimacy remain insufficiently measured. In neurological women, the comparison between artificial sphincter and fascial sling is still limited by small sample sizes, but both options appear possible. On the measurement side, quality of life questionnaires in stress urinary incontinence are not all equivalent. Some commonly used tools rely on fragile content validity. A Jordanian consensus on a home-based program also reminds us that a protocol is not just a list of exercises. Cultural adaptation and feasibility matter. In endometriosis, Dienogest seems to mainly improve dysmenorrhea in a small cohort, while nodular rectal surgery may reduce defecatory dysfunction compared with segmental resection in selected profiles. Finally, in refractory constipation, manometry, balloon expulsion testing, and MR defecography do not always give the same diagnosis. And in systemic sclerosis, anorectal manometric abnormalities are frequent, especially an abnormal rectoanal inhibitory reflex. Conclusion: this week, the Prolapse dossier logically sits at the center. It connects menopause, vaginal tissue, pessaries, surgery, mesh, sexuality, and long-term outcomes. The must-read papers then shift the focus toward urgency urinary incontinence, postpartum stress urinary incontinence, obstetric sequelae, rectovaginal endometriosis, and bladder-bowel links. The common thread is not a technique. It is the quality of the decision, choosing the right success criterion, measuring more than anatomy alone, and not confusing symptom improvement, tolerance, durability, sexuality, and quality of life. Thank you for listening. Always check the full papers and official recommendations before changing practice. References are available in the description, and see you next week for another edition.